Hi, and welcome to the Frank and Lizzie Show. I have the honor of sitting with Frank today. We're at SAWC Fall, and we're going to be talking about a technology that's going to make life a lot easier for clinicians at the bedside. So I think, Frank, you know, for years I've been passionate about pressure injury prevention. I was the lead of my health system that kind of determined the decision trees of who gets what intervention and why. And of course, I know you've done a lot of work in pressure injuries, particularly with nutrition as well.
Mm-hmm. And you know, Liz, what I really see out there is that there's still a problem across the continuum of care, despite all the increased awareness.
Yeah.
So I agree with you. And because of all the work that you've done, it really rubbed off.
God. So today we have the honor of interviewing Martin Burns, who is the CEO of Bruin Biometrics, and he's going to talk to us about the Provisio SEM scanner. Welcome,
Yes.
Martin.
Thank you very much to both of you. It's lovely to be here.
Well, first and foremost, Martin, you know, I want you to share with the audience and I what this Provisio SEM scanner is.
Well, here it is, and I'll demonstrate it to you in a minute. But what it is a way of detecting damage that's occurring underneath the skin surface that actually is microscopic, so very, very hard or actually impossible to see from the naked eye. So the whole idea behind it is really simple. Damage is occurring underneath the skin surface before you can see it. We know that. It's never been measurable. It is with this. And when you measure it, you've got a condition that then needs to be treated. And when you treat it, guess what happens? Skin remains intact. Nurses are then equipped with the information that they use for their best practice. Nurses are trained to treat. This gives them the information to treat, and they're really good at it.
I like that.
Yeah, I like that too. And what I really like about it is that it's really objective. And I think having anything that helps our clinicians at the bedside determine what's black and white. So we would never treat a blood pressure without knowing what the blood pressure is, but we do this in pressure injury prevention all the time, where we're choosing interventions and kind of dictating to the patient what's part of their treatment plan without having an objective, measurable something to work on. So this is really giving you that data that you can work on. And just for our audience that may not know, SEM of the SEM scanner?
Subepidermal moisture.
Okay.
And by the way, you guys as clinicians won't ordinarily think of SEM, but you will think of persistent focal edema. So persistent focal edema is the long-standing clinical term that's been in ICD-10 for decades. And it was renamed subepidermal moisture by Barbara Bates-Jensen at UCLA. And we took it and ran with it because it had some slight differences, but basically it's persistent focal edema.
Well, Frank has a lot of experience with edema.
Yes,
right,
you do.
and I can tell you that everywhere you look, edema will decrease the oxygenation to the skin and the tissue.
Yep.
So if you're able to detect it before the eye sees it, this is phenomenal. And what I love about this, it's black and white. Mm-hmm. There's no trying to guess what it is. And so for clinicians, this is wonderful because now you can allocate resources or conserve resources to where you need them to go to, especially nowadays with all the constraints that we have.
So Frank, there's two parts of what you just said there that are incredibly relevant. The first thing is that persistent focal edema, SEM, is now been shown to be both pathophysiological and etiological to the later onset of broken skin ulcers. So etiological to skin ulcers, pressure ulcers, and then also part of the damage cascade that leads to the ultimate broken skin ulcer. That's now established and it's in the literature, so that's very important. It's not just a risk factor anymore. Mm-hmm. The second thing about it is that, and you mentioned this black or white, and you're both sort of wearing black and white here almost.
Shoot! We didn't even plan that, you know?
Yeah, right.
Yeah.
So it is very black or white. And so for clinicians, what's happening is at the bedside, as opposed to just leaning on habits and rituals, risk assessment, some clinical intuition, what they've now got with this instead is the ability to say, you know what, my patient George over there, his left heel is compromised. It doesn't look red, but the SEM scanner is saying there's a problem. I'm going to go focus on George's left heel. What it then also is saying to you is, and therefore I don't have to worry about his right heel or his sacrum or any other part of the body, which means when you look at time motion studies, instead of treating everybody the same way based on a risk assessment, which is universal or total body, what you instead do is get really focused. And when you get really focused, you save time. Guess how much time? It's about 7 hours per ward per day of nursing time, not spent on that habitual and ritualistic care, but rather directed untreatable condition.
And I do want to interject here real quick, since we were in black and white. You know, when I did a lot of research on pressure injuries, one of the things that I noticed is that skin color makes it hard, because what we do is we use for visual assessment, and there's an article out there that said maybe 60% accurate. And so tell us, is there black or white? Does the skin color play any effect on your device?
So all of your audience will know the issue of dark skin tone assessments, and they probably will also know some of the mortality rates, that dark skin tone patients die at a rate 4 times more than any other cohort. So as an example of patient inequality, this is it. And given the fact that pressure injuries are the #1 reported patient safety event in most settings across the United States, you're talking about the #1 leading cause of health inequality across the United States. Now, with technology like the SEM scanner, skin color becomes something you no longer have to worry about, because that works on all skin tones. So now skin color is not the barrier for your ability as a clinician to be able to say, I need to go treat that patient's heel or not treat that patient's heel. It melts away. It's so important that when I go to Congress, this is the topic that they bring up over and over and over and over again.
That's phenomenal. So thank you for sharing that.
So I know that this device has been out for some time.
Yep.
And so certainly there's data around it, I'm assuming, right? So do you have kind of a high-level overview of what your summary of data is that clinicians should know about to bring this into their institution?
Yeah, for sure. So in the data world, I think probably there's a couple of summary things I could say to you. So first of all, we've got so much data now. There's about 150 publications, peer-reviewed articles, oral presentations from all over the world, both by us as Bruin Biometrics, but also independent researchers. In fact, I was doing the mathematics of it recently. If we were to put out a metric of how many publications we had produced in the last 3 years, we've got 1 publication every 45 days, which puts us as the #1 research institution globally on the topic of PI prevention and subepidermal moisture. So there's a lot.
Yeah.
But without overwhelming you with all of it, let me just break it out into 3 distinct chunks. Chunk #1 is the detection of SEM. So all the etiology, the pathophysiology we touched on before. Category #2 is the treatment of SEM. Okay, you've got a reading. What do you do with it? Well, all the different treatment. But neither of those 2 things really matter as much as the third category, which is that once you've detected and treated it, what are the prevention outcomes you're actually getting? So there's all of the prevention data that shows clinical prevention, keeping skin intact is how we talk about it, and then all the health economic consequences, the great impacts on nursing time, nurse stress, and then the patient outcomes as well. There's lots of it.
Yeah, we'll have to dive into that one day, and hopefully we'll see it come forth in the 2025 guidelines too.
I would hope and expect that to be the case.
Yeah.
We already have clinical recommendations.
Yes.
And for anybody who wants to get the data, we have one document which summarizes all of it called the Clinical Evidence Summary. If you email us, we will send it out to you.
Okay, sounds good.
I want that. So let's look at the device. How easy is it to use?
Okay, so it's handheld, it's wireless, meaning it doesn't have a wire attached to it, and it also ports the data wirelessly to the Wi-Fi point, so it connects to the electronic medical record. It uses a sensor, which is this thing here, and it attaches onto the device here, and I'll show you that in a second. As a nurse practitioner at the bedside, you have the choice to be able to scan your nurse barcode and the patient barcode, so you can match the data together with the diagnosis you're providing. So what you do is you take the sensor, it comes in a little package like this, and you put it on the device.
Easy.
And then you just press go. And what it's doing is do you know the kitchen scale when you're kind of reducing it to 0, it's called tearing the device. And it's basically tearing out parasitic capacitance out of the unit, all the noise. And you can either barcode scan the patient and the nurse, Or if you don't have that, some nursing homes don't use that. So you just do the bottom one, and up come the anatomies that you can actually scan. And we've put in there sacrum, left heel, right heel. So let me just quickly demonstrate it to you. I've just touched the left heel. There are two circles. The big circle is the, well, you'll see, I might as well just demonstrate it as opposed to show it. Let me just do my fingertip.
Okay.
So what's going on is that lower circle there has the absolute value, 2.4. That's a measurement of moisture at my skin, underneath the area of the sensor. I'm going to do it again, 2.5 that says. I'm going to do it again, 2.5, so it's basically very consistent in the reading. And you see the way it's got a green circle? Well, that green circle would say you've got equal distribution of moisture at my skin, the fingertip. But if I'm scanning the heel and you get a green circle like that, what does it say? Well, the distribution of moisture is normal. Move on, go to the next patient. I'm going to trigger an abnormal value for you because then you can see what happens when you actually have an abnormal reading. Now, my fingertip won't do it.
Is he going to spit on the finger?
I don't know.
I'll do what all bankers do when you demonstrate this to them, and I'll do it on my forehead. Oh, no, that didn't do it either. Here, we do it here. There we go. So on my chest. So you see the way it's got 1.9
Yeah.
there, and the orange circle. Well, now I know. I've got a distribution of moisture that's above a threshold. It's abnormal. And therefore, what do? Well, now you go back and you look at the patient, and I now know that that right heel is problematic. Go treat the right heel. Now look, you guys have got clinical backgrounds. You know this way better than I do. If you've got localized edema that you know is both pathophysiological and etiological to later skin damage, in other words, this precedes and predicts later skin death, what are you going to do? Well, you're going to alleviate pressure. You're going to mobilize the heel. You may put a heel boot on. You may put a dressing on. You're going to pay very close attention to it. You'll rescan every 8 hours. You'll go back and you'll look at it. And when you do that, the reduction in the incidence of broken skin ulcers is around 92% on average, and in most settings is 100%.
Wow.
Well, certainly, I think the impact of preventing a pressure injury, that's huge. That's kind of the personal thing on it, that we want to help our patients. We want to stop that. I'm going to put a business hat on for a minute and say that really you're helping the diagnostics about diagnosis. Because if I'm doing this to my patient on admission, now I have a present on admission, which we know here in the States, it's a big deal, whether it's a hospital acquired or a present on admission. So I think that's also part of the glory of it, is not just that you're preventing pressure injuries, but you can also say, yo, you came in like this. And certainly in the amount of legal work that we do, and being in my field, I've seen plenty of it where it's pulling hairs of where this happened and how it developed. And so I think this is a great technology to help us really diagnose, and hopefully physicians then can get on board. We've seen just such a lack of education around pressure injuries and how to diagnose or stage. And so having this delta of, is it 0.6, right?
0.6.
0.6 is kind of that defining delta that says you're in trouble or you're not.
Correct.
Yeah, and it's color-coded
It
for
is
those of us
color-coded.
that don't know how to read. So, yeah.
Yeah, and actually, I wish now that my hospital has that, because I don't know if I told you, but I fell, and when I landed, I had fractures. And so when I went to the ER, the first thing I said was, "You're going to turn me. You're going to make sure my heels don't break up," and And I'm looking at these people going, so I wish I had that, because I'd be demanding every hour, scare me.
Yeah, for sure.
Exactly.
So just briefly, the present on admission testing is a really big use case, actually. We see that all the time. And the Medicare penalty 1%, based on the PSI 90 composite risk assessment measure, is back again, which means there's a 1% penalty if you have stage 3 and 4 pressure injuries. Present on admission anyway is actually complicated because of the time window you have to do it in. And it's very fast moving, as you know.
Yeah.
But actually, what we see in the dozens and dozens and dozens of systems all across the US using this is that issue has been sharply reduced. And then it has consequential actions based on where you were going on insurance premiums in particular. So the risk profile for that system goes down, and it starts from the door.
Wow.
That's great.
Yeah.
Well, Thank you so much for coming and explaining all this. I think the audience is going to eat this up, quite literally. I think it's going to be a great technology to integrate, and we look forward to hearing more about it in the 2025 guidelines.
Yeah, and
From
thank
your
you so
lips to
much.
God's ears.
I've been hearing a lot about the device and you, so I'm glad that you were here on our show. And
Thank you for
glad
the
to meet
invitation.
you.
Yeah, thank you very much, and thank you, Liz.
Be sure to like and subscribe to the Frank and Lizzie Show for more content and to get any updates from Provisio.